Good morning, everybody. My name is Paul Devlin. I'm Trust Chair at Nottinghamshire Healthcare, and I'd like to welcome you to our Board of Directors meeting, whether you're watching live or indeed watching a recording. You're very welcome to join us. Just to say at the start of our meeting that we are a couple of people down temporarily because they're involved in a presentation to the Care Quality Commission, the CQC, who have arrived to do an inspection of Rampton Hospital. Hopefully we'll get an opportunity to feed in a little more on that. It just means that the agenda might get moved around a little as we work through the business today. And to say that at most of our public boards, we start off with a patient story to help focus us on the experience of those who are using our services. Today's one, we're actually taking in our Part 2 confidential board because the patient involved is in receipt of some of our forensic services. So there's a level of confidentiality that we need to hold. But I just wanted to say in the public session that we will, of course, be listening to somebody who's in receipt of our services about their experience a little later on. So if I could begin with some welcomes and introductions. There are one or two changes that I need to mention. We will be joined as soon as possible by Anne-Maria Newham, who is our Chief Executive following the retirement of John Bruin at the end of August and prior to Ifti Majid joining us as substantive Chief Executive. So Anne-Maria is Chief Executive up until Ifti joins, and we'll be able to introduce herself as such when she's able to join this meeting. And as a result of that, I'm also delighted to welcome Tabitha Darman, who's the Interim Director of Nursing, AHP and Quality. And Tabitha is stepping up for Anne-Maria. And today we're also joined by Keely Sheldon, who's stepping in for Becky Sutton, and John Singfield, who's stepping in for Jan Sensier. So I think those are the new people that I need to mention. Everybody's very welcome. So if we go to apologies, and we've got apologies from Becky Sutton and Jan Sensier, and also from Sue Nixon as well. So could I ask if there are any declarations of interest, please, for the part 1 of our board meeting? I'm not getting any through for today, so in which case let's go to questions received from the public. There are 2 sets here, and the first one is some family members have written to us with some really quite specific questions about the care of a family member, and just before I invite Julie Atfield to give a bit of a response to that, is just to say that we don't talk about individual cases in our public board. What I will be doing though is making sure that the detail of the question is shared with the board in our private part 2 session. Julie, do you just want to add a couple of words on the back of that, please?
Yes, so appreciate it's a difficult time for this patient and their family, and as the chair suggests, it's not appropriate to discuss individual cases at the public board, but I can confirm that there is planning for the onward care of this patient in train, particularly with the input of our specialist services, and a new plan will be discussed with the patient and their family in the next few days. I am cited on it and will continue to be. Thank you.
Thanks, Julie. As I say, I think it is really important, as you say, that we hold the confidence around an individual patient and their family, but to just reassure the family that the detailed questions will be shared with the board in the second part of our meeting. Then a second question, we've had a question from one of our members of staff who's asked us many questions actually over the last couple of years regarding aspects of COVID and our approach to COVID. And this question is, how is the trust supporting staff who've been injured by COVID jabs? So Tabitha, could I ask you just to give a response to that, please?
Thank you, Chair. My name is Tabitha Darman, Interim Director of Nursing, AHPs and Quality. In response to that, we do support all our staff in regards to COVID or anything that has got issues around their health and well-being. And again, I can't sort of discuss individual staffs online, but you can be assured that all staff are given the right support at the right time, and the information that we give is in line with statutory guidelines. Thank you.
That's great. Thanks very much, Tabitha. In which case, let's move on, if we can, to the minutes of our August meeting. And can I just ask colleagues, first of all, if you can give me an indication of whether you're content to receive these as an accurate record, please. I'm getting some responses there from colleagues. That's great, thank you. And in terms of matters arising, there was the action log. There was only one item on the action log which has been completed. So I think that we can move on from that unless anybody's got anything else they wanted to bring back to us. Okay, so if we go to my report, there's just obviously take it as read. There's a couple of things that I did just want to mention. First of all, to recognise that since the last board, we've had a period of real extreme weather, and it's a little odd given how stormy and thundery it is over the last couple of days. But just to remember that for a couple of weeks, our staff and patients were experiencing incredibly high temperatures, which was really challenging in some of our services. And I just wanted to acknowledge on behalf of the board a big thanks to staff for being able to work through in such challenging circumstances. Also, just to say a little about the Care Quality Commission. As I mentioned at the start of the meeting, they have arrived to carry out an inspection at Rampton Hospital, and I know we'll be able to hear a little more about that from Anne Maria, and she will talk about other aspects of Care Quality Commission and some of where we're at with them. I think it's also really important just to mention that last night we were able to have, for the first time in the last 3 years, a face-to-face celebration of our annual staff awards, the Oscars, and it was a fantastic evening. It was a chance for us to really celebrate some of the amazing things that our staff have done, to be able to really get a chance to focus in on and hear about fantastic work from people across the whole of the trust, and to have some good time together as well. So it was a fantastic evening. I would want to say that our communications team did a superb job in making the event as successful as it was, and also to give my thanks to Sarah Julian from Radio Nottinghamshire, who did a superb job hosting. So I'll just pause to see if there's anything else anybody wanted to pull out of my report. I'm not seeing that. So just to say, for anybody who is observing us, we have now been able to be joined by Anne-Maria Newham, Susan Elcock and Carolyn White. So that's great timing, and we'll move to the Chief Executive's report if we can. Anne-Maria, over to you, please.
Good morning, Paul. Thank you very much. Hello, everybody. My name's Anne-Maria Newham. I'm the Chief Executive Officer today. So yeah, thank you for that. Apologies, everybody. I was a little bit late, so I've just been presenting to the CQC. It went very well, so I just wanted to let people know that. So yes, I want to take the report as read, but there are a couple of things that I would like to just point out and bring to people's attention. So with regards to the CQC, we do actually have them on the premises at the moment. They are inspecting Rampton, and which is overdue, and we welcome them being here. There's quite a big team, and we've just done a really, really good presentation that was well received. But I just wanted to point out within the report that we did get a warning notice, 29A, from the Health and Social Care Act, section 29A, warning around our dormitories. And we did appeal that notice. However, this has not been upheld, and the improvements are required to be completed by the 27th of November. We will discuss that later, and Julie Atfield, who'll be on the call today, will be able to give us a little bit more around that. I just also wanted to pull out a couple of bits from each of the divisions. So with regards to the mental health division, we've had a bit of a setback with regards to the full handover of the Sherwood Oaks building. It was unfortunately delayed at the end of July. So staff have been able to access the building for limited familiarisation, and so the timescales of the occupation of those wards are just currently under review at the moment. I just also wanted to mention something very good is around the long-term plan. The transformation is progressing really well with that, and we've had a rollout of mental health practitioners in primary care, and we've had a total of 21 whole-time equivalents being recruited, with many well established in the primary care networks. So we're receiving some really good feedback about that, and those roles have gone down really, really well. The next one I just wanted to point out is around the Community Health Division. We were thrilled to announce that the Children and Young People Services, Community Health Services, has retained the prestigious UNICEF Baby Friendly Gold Sustainability Award, which is a really big achievement. So just a big congratulations to them. And also just to mention the Discharge to Assess Pathway 1, that's around home care. So patients coming out of the acute hospital into the home care, that's classed as Pathway 1. That transformation business case was signed off from the ICB, which is the Integrated Care Board, on the 11th of August, and now we can move into a full implementation of that. And within our forensics division, I wanted to just mention the Assertive Transition Service has been awarded to the Notts Healthcare to mobilise a region-wide service alongside our partners St Andrews, Rethink and Framework. With regards to Arnold Lodge, we did have some issues, and I know it's been reported previously within the Trust Board around how difficult it's been to recruit to Arnold Lodge and some of the vacancies that were sitting within Arnold Lodge. Well, we've had a huge success recently where we've been able to recruit 51 staff, 8 of which were qualified. So that was just a really good news story to be able to bring to you. Now, John did retire last Wednesday, but I did want to say something that he'd gone to and I had gone to as well. And I just wanted to pull it out because we were I think we were both so overwhelmed with how amazing it was. So we went to an event called the Trauma Conference, And I got to meet Terry Waite. I'd never met him before, but John had met him for a couple of times, and it was an event. It was a fantastic event and a celebration of the work of the Centre for Trauma, Resilience and Growth. And they had a day where people came together to speak about things like being a hostage, how it had felt, or being in a trauma situation, taken as hostage. And they had 4 different speakers that were able to give their stories. And this is a really interesting kind of team that are attached to us as an organisation, and the work that they do is really amazing. So I think that was worth just a mention, because it was really, really inspiring. And of course, we had Pride Month, which was held on Saturday, the 30th of July. I'm not sure if Paul's just mentioned that. I know that he was heading up that, and he thoroughly enjoyed it. Also, what's coming ahead, and I always point this one out because it's such an important one for us as an organisation, is the World Suicide Prevention Day, which is on the 10th of September. And the theme this year is creating hope through action. So a Trust Suicide Prevention Conference is being planned for the 10th of October. Such an important day for us, particularly with the work that we do. And I know that that Paul's just mentioned the Oscars, which was a great event, huge celebration. Staff thoroughly enjoyed themselves. Great to be able to do something face to face. And that's my report today. Thank you, John. Paul, I keep calling you John. Paul. Paul.
Thanks, Anne-Maria. So let me just, I know you've teased out a number of points there. Let's just see if there's anything anybody wants to pick up, either from what you've said or from other parts of the report. As ever, it is a very comprehensive report for us. I'm not seeing anybody wanting to pick anything further up there, Anne-Maria, thank you. So let's move on, if we can, then to item 9, which is the Integrated Performance Report. Alison, if you could do your usual job of steering us through this, please. Over to you.
Thank you, Paul. My name is Alison Wilde, the Executive Director of Finance and Estates, and I'm here to provide you with assurance on the performance of the organisation against regulatory standards and internal targets. The purpose of the report is to inform the board of the main areas of change, and it's for the period month 4 up to July 2022, April to July 22. So in terms of moving us through the report, the approach is about exception reporting, and criteria for exceptions are about positive improvement or where the trust has failed to meet local or national standards or any areas of significant variation. So I'll move us through the report and start off with a quality of care overview. So I'll hand you over to Tabitha Darman for that. Thank you.
Thank you, Alison. Good morning, everybody. My name is Tabitha Darman, Interim Executive Director of Nursing, AHPs and Quality. The board are requested to note 2 areas where within quality we're having challenges. The first one being the national issue around safer staffing for our wards and areas that are lower than 85%. So over the last 13 successive months, I think we've seen and been challenged around our staffing. And we have got 20 wards where we're mostly challenged. Out of the 20, 15 are within forensic division. And we all have work that we're doing to try and support and reduce this. The good news out of it is that we have not seen impact on our patients around safer staffing, but it remains a significant issue, and we will work with people and culture to see if we can resolve the issue moving forward. The second bit is around our sequin targets. We've managed to achieve all our sequins except for one around the CCG13 malnutrition screening. And this is because of failing to achieve due to data and inputting, and the division, which is mainly in our community health services. And I think Hilly will talk on this as well, to support with doing specific work, targeted work, to make sure that we achieve the required target. Thank you very much.
Thank you, Tabitha. And could you or somebody just remind us what CQUIN stands for, please? I can't remember it off the top of my head, and I'm sure yourself or another colleague will be able to remind me.
Commissioning for Quality and Innovation.
Thank you very much. No, don't worry, but it's just important when we're in public that we manage some of those acronyms as we go through. So let me pause there, Tabitha, and just see if there are any questions or comments from colleagues, please. I did just want to, if nobody else wants to ask it, Tabitha, and it may be a bit unfair to ask this directly of you, so other colleagues might want to come in. In terms of the safer staffing, whilst I appreciate the managing of impact there, it's starting to feel like a bit of a kind of a wicked problem for us at 13 months, and I just wonder if there's if there are any new ideas of things that we're trying that again either yourself or somebody else can feed in on this, because it's one that we've talked about a great deal, and I know there's a lot of effort going in. It's about how we whether we're able to crack this. I also appreciate that there's a national issue as well, but I wonder if you could just respond to that a little.
Thank you, Chair. There is work happening because within the integrated care system, which I am part of the integrated care system nursing and midwifery cabinet, we're doing like joint work to see how we can grow our own as a region as well as international. And we're also responding to the Chief Nursing Officer for England, who has asked us to do a retention assessment tool, which will help us hear from our staff in terms of what is it that we can do to keep the staff we've got, what is it that we can do to grow our own staff. In terms of growing our own staff, we're working with Health Education England, and we're also working with our local higher education institutes to see how we can actually support, you know, students who are coming out of training to make North Healthcare their place of choice. So there is a lot of work happening in terms of like looking at how we can even target schools and make nursing attractive profession for staff, for children who are growing up to come to us. There's a lot of work happening, but it's all long term, which is appreciated. And we also have the international nurse recruitment, and hopefully by end of December, we'll have about 30 nurses who are coming from abroad who we can keep if we look after them. Thank you.
That's great. Thanks, Tabitha. And I'm sure that when we get to a later section around some of our people work, this is something that we can come back to a little bit further. So if I could invite Paddy in, please, and then Nigel. Paddy.
Tabitha, that was really helpful. Thank you very much. You mentioned the retention of staff. The staff turnover is extremely high at 17%. When you take TUPE out, it's a bit less than that. But you know, compared with other people, that is quite astonishing. What can we do to address that?
That's why we're being asked by the Chief Nursing Officer for England to actually talk to the staff and hear from them to say, what is it on top of what we are already doing? What can we do to retain? And part of it, what's coming from the staff I've spoken to, is the career progression. We need to look at how we can develop our staff when they join us, and show them the progression to say from a band 4, you can do the trainee nurse associate and become a nurse associate. And from that, you can become a band 5 and registered by the NMC. So we need to do a lot of work around career progression and development of our nurses, also nurturing them and providing them with health and well-being, supporting them. So the Trust now has implemented professional nurse advocates to support health and well-being. which is another initiative to try and keep the staff we've got. So we're doing a lot of listening and hearing from the staff in terms of what is it that we can do to keep you.
So Paul, again, that was really helpful. Elsewhere in the report, there's been an increase in appraisals, and again, that's a good thing. But appraisals need to be of high quality, and my impression is that it's a bit variable across the trust, and it ties in with that professional development that you've just been talking about, Tabitha. I mean, clearly you cited it on that, and you think we're making progress.
I think we are. We're working very closely with people and culture, and at the moment we're reviewing our appraisal process to see how it can become meaningful and actually support staff meaningfully.
Yeah. And I think Jen Guyver will be able to say a little bit more about the turnover when we get to the people part. I think if we hold it till then, Jen. Can I just, before I bring you in, Nigel, Keely, can I just ask you just to give a just to add a couple of sentences around our approach to safer staffing, because I missed you a little earlier. So Keely.
No worries, just to add to what Tabitha was referring to around that 15-month complexity around achieving safer staffing. I think historically we have been doing care per hour per day, which gives you a number of staff that are required on at each ward and your fill rate to those staffing numbers. We meet monthly as a safe staffing group to ensure that we're continually learning around alternate opportunities to achieve safe staffing. But in addition to that, we're also implementing the Safer Care bundle across our services. What this does is give us an opportunity to review our establishments from a skill mixing perspective, so where we can meet those staffing levels from an alternative skill mix. So for example, when do we need qualified nurses, when do we need nurse associates, and when do we need healthcare support workers to help us achieve that overall safety issue.
That's great. Thanks very much for that additional information, Keely. Nigel, can I come to you, please?
Thanks, Paul. Nigel Smith, Non-Executive Director. Tabitha, I just want to follow up on Paul's question if I can. It does seem to be a wicked problem. It's been going on for 12 months, and I've come to the conclusion that it's not going to go away soon. Despite all the efforts that you're making, I think it looks to me like we might be looking at similar numbers for a while yet. And therefore, I think I should ask really about the impact of the staffing shortages on patients. I wonder if you could just comment on how this impacts on patients, and if we're confident there are no safety issues for patients, what is it that makes us confident that we've got that covered?
Thank you, Nigel. I'll try and answer that. I can assure you that there is monitoring every day within divisions to look at this staffing numbers and making sure that they are safe numbers to maintain patient safety. So far, our incidents don't show any impact of the numbers of staff in relation to the fact that we are struggling because we're using bank, we're using agency, and like Keely mentioned, we have to think about skill mix rather than qualified staff. So we are ensuring everywhere there's reviews on a daily basis, monitoring on a daily basis, staff deployment to ensure that they go to those areas that are higher acuity and need more people. All that's happening on a daily basis. So far, I can assure you that we haven't got incidents that relate to staffing numbers, and staff are very good at escalating issues when they're short. They escalate the issues.
Oh, thank you.
Thanks, Tabitha, and I think Sue Elcock will be able to just give a forensic side on that when we get to that part of the integrated performance report. Just to say, one of the things that's really interesting today about the integrated performance report is the fact that we're highlighting with your piece of the report, Tabitha, things that are then also being looked at and dealt with and picked up in other aspects of the report, which is exactly what an integrated report should be doing. So let me go back to Alison. Thanks, Tabitha. Go back to Alison and steer us on, please.
Thank you, Chair. Alison Wild, Exec Director of Finance and Estates. I'm moving us on to the People and Culture overview now and the exceptions to Jen Guyver. Thank you.
Good morning, Jen Guyver, Executive Director of People and Culture. So I'm going to take the report as read, but just pull out some positive highlights and also some areas that we obviously still need to work on the people domain. So in positive news, board, if you cast your mind back to the springtime, we had a really deteriorating position on the number of our staff who'd received an annual appraisal. And we took some action over the summer and that's really paid dividends. We've seen a 10% or just over a 10% increase between May and July in our appraisal compliance. So we're now at 85.9%. And we're going to repeat the that exercise that we did around data accuracy and chasing up again from this week. So hopefully we'll be able to maintain that position. Secondly, Paul's right, everything sort of links back together, which is showing that we are truly integrated on the work we're doing. A lot of what Tabitha referenced and probably what I'll reference in this section will come together as part of our people plan. That's been signed off by the people committee in a couple of weeks' time, and then we'll go to our Council of Governors during October for final board sign off at our November board. And within that, it contains our aspirations to truly be diverse, inclusive and a great place to work. And some of those projects that Tabitha mentioned, professional nurse associates, projects around retention all feature within our plan. So they're the couple of sort of positive progress for this month. In terms of challenges, turnover, so we've touched on that already. As I've said at the last couple of boards, turnover is a long project. In the context of the whole of the NHS, and we are seeing a higher turnover rate. People who did stay on to support the pandemic effort are moving on and retiring. So it is a national picture, but that said, the Notts Healthcare turnover figure is higher than other trusts or other comparator trusts. So there's clearly work to do there. I've said before, there's some things we can do on a short-term basis. So we're developing a new exit interview process. We have a number of retention financial incentives in some areas, but this is a longer term project and all links to achievement of our people plan essentially. For board's assurance, we are actually taking a paper with detail on turnover to the people committee on the 20th of September. So that details some lots of data around starters versus leavers, and goes down into divisional areas so we can be assured that we understand the picture and what we're doing about it. Moving on to other areas, as predicted, due to the latest pandemic wave, we have seen an increase in sickness during July, and that has now come down during August. So at October's board, that figure will improve. Just that there's a bit of a watching brief needed on this statistic, because actually the latest wave, although our sickness absence figures very much mapped against community prevalence of COVID-19, actually what people were reporting in sick with was not necessarily COVID related. So we saw a decrease in COVID related sickness, and I think we need to let that flow out for a couple of months to truly understand it and act on it. And then finally, our temporary staffing spend remains an area of concern. We've had a new member of the team start this week, who's leading on an improvement project for temporary staffing. So that we've got some positive action about to kick off in that domain. The idea being, one, to reduce reliance on agencies, but also improve the offer for our bank workers. They're part of the Notts Healthcare team, and we need to make sure that they're treated as such and they have a good experience when they're working with us on a flexible basis. And that was what I wanted to highlight.
Great, thanks, Jen. Got some questions coming through to you. So if we can go to Trevor first and then Manjit and Carolyn. Trevor.
Thank you, Paul. Trevor Allman, Non-Exec Director. Jen, thanks for the update. The recruitment and retention is obviously an issue for not just for the trust, but a nationwide problem. We've got the trust, the system-wide, and then the NHS in total. Is there the right level of coordination and help going across what we can do internally, what we can do with the system and government direction to make sure not just us can get out of this dilemma, but the wider issue is being addressed?
Yeah, so NHS England have funded some retention leads. So we're going to be having a retention lead in the system, contractually reporting into the ICB, but we'll work really closely with myself and the other people directors across Nottingham and Nottinghamshire around things we can do as a system, as you say. We've got a really well progressed people governance structure in the system. In fact, my deputy's at the system people meeting as we speak, and really good relations across the people team. So I think there is a lot we can do as a system. I would say that turnover is a lot to do with how it feels to work in an organisation. So I think that needs to be the focus around making sure that people want to work with us, want to stay with us, want to progress their career. And as you know, the people plan covers that off in terms of development opportunities, support, both formal and informal sort of development and learning opportunities.
Lovely. Thanks very much, Jen. Thanks for that response.
Thanks, Jen. And you snuck in an acronym there of ICB, the Integrated Care Board, which is the piece that oversees the system there. So if I can go to Manjit, please. Manjit.
Thank you. Good morning, Manjit Darby. I'm a non-exec director in the organisation. Thank you, Jen. I think that in the People and Culture Committee, we've got a fairly detailed line of sight on the work that's happening. So I'm reasonably comfortable about the work plan. My question today really is, when we think about what this report is telling us in terms of turnover, sickness, the use of agency, and safer staffing breaches. We're headed into the winter. We haven't had the respite that we would normally get during the summer to aid recovery of staff and kind of gearing ourselves up for winter. My guess is that we're headed to quite a tough winter in terms of the staffing challenges that we're going to get. What are we doing as an organisation by way of winter planning and thinking about being able to tackle the challenges of being able to meet patient needs head on, given that we haven't got the summer respite that we would normally get, and these problems aren't going to go away?
Okay, so at a corporate sort of trust level, it's all about recuperation, recovery, making sure we're supporting staff, I think, during this period. And that's certainly what we're trying to do in terms of our new wellbeing team. So we're ramping up the wellbeing offer, and we're starting some back on the road, so that people can put faces to names and actually access support. So getting out to sort of people that wouldn't necessarily engage in the virtual world, and making sure people know what the support offer is. In terms of winter planning, I'd probably hand over to some of my ops execs, because there's winter planning happening, but it is by specialism. So there's a mental health winter plan, and they're all in various stages of development. So I don't know if anybody wants to come in on that with any detail around the actual operational winter planning.
Yeah, I mean, while somebody's thinking about that, one of the things that I think that as a board member, I think that's something really important about the modelling that we are doing in terms of sickness, and our modelling predictions in terms of managing worst case scenario. That's the bit that I'm interested in.
Should we just see if there's let's just take a couple of comments from operational colleagues just so that we don't lose this point. Julie, do you just want to give a comment, and then perhaps if I can go to Keely and Sue as well.
Yeah, so I'm Julie Atfield, Director of Mental Health. Manjit, I was going to pick up sort of winter planning in the IPR actually. For us, our winter plan is done really. It's also about bolstering different access in terms of the pathway to try and take some pressure off our services, and also some of the bolstering that we did last year will continue, particularly around, you know, children and young people's crisis. So those sort of step ups are available to us now. So I think that, you know, learning from an equally challenging period, I think last year, but for us it's key to make sure it's not all our staff that are all the capacity for those plans.
Great, thanks Julie. Keely, anything you'd want to add to that?
Hiya, thanks Paul. Keely Sheldon, Deputy Director for Community Health Services. So just to build on what Julie says, internally we're working on our winter plan of how we can sustain and build a resilient workforce as well as services for our patients. In addition to that, there's been several system workshops that have also had that collective discussion of how across the system can we play our part in ensuring a resilient workforce and services. And in addition to not only thinking about winter, I know that Nottinghamshire had a critical incident with regards to emergency care at end of July, and we've taken critical learning from the critical incident from a cold debrief of how we can sustain some of those actions around business as usual to prevent a future critical incident or support us with our winter planning and forecast to move forward. I think in addition to that, Community Health Services, we held a coffee and chat with our workforce last week to understand from their perspective what will support their team or service to get through winter this year, but what will support them as individuals to sustain their mental health and well-being and resilience through the winter period, and what they require from Notts Healthcare to achieve that. And in addition to that, I know Jen's team, we've got some wellbeing road shows coming out to team bases over the next couple of months to really support staff with where they currently are in preparing themselves for winter. Thank you.
Thanks Keely. Sue, is there anything you'd want to add to that from a forensic perspective?
Hi, Sue Alcott, Forensic Director. To be fair, no, I think what Keely has said is the same for us as well, actually. So thank you.
Great, thanks. Manjit, does that help give a flavour of at least how the team are on it?
Yeah, no, really helpful, and we'll carry on tracking that, I think, in people and culture as part of our responsibility. So thank you.
Great, let's go to Carolyn, please. Carolyn.
Good morning, thank you. Carolyn White, Non-Exec Director. Jen, and this might be a question for operational colleagues as well. I'm a bit concerned about the target in terms of agency reduction. I wouldn't normally be a great fan of agency staff. Having our own staff is obviously a preference, but that 23% target for the ICB seems high given the pressure that there is in the system now and that we're anticipating for the winter. And I suppose my concern is that if we work towards that target reduction, that pressure gets pushed into our substantive staff who may be asked to do extra overtime, bank work themselves to cover that. And I just wonder what we are doing to kind of monitor that in terms of our own staff's wellbeing.
Okay, Carolyn, so just to assure you, we need to move towards that target, but not in an aggressive fashion that means that people are forced to do extra hours, etc. And I know that's not what you, but I think it's really important that we maintain people's well-being at the same time. I think there's definitely more we can do for our bank, and by bank I mean bank only, and translate some of those agency shifts into bank shifts. The other thing around agency is that 23% reduction is around spend, and agencies are on a spectrum of how expensive they are. So some of that work is around not necessarily less agency shifts, but shifts that are within the NHS England framework, are within the cap, and are not the most expensive agencies. So that will be what we would work on, rather than trying to sort of transfer agency shifts to our own staff doing extra hours.
Okay, does that include medical staffing in that target?
Yeah.
Okay, so that's
all
obviously a big cost, isn't it, as well?
Cost.
Okay, yeah, thank you.
Great, thanks for that. In which case, thanks, Jen. Alison, if we could move on to the next piece, please.
Thank you, Chair. Alison Wild, Exec Director of Finance and Estates. So we're moving on into the integrated performance report to our operational divisions, and we're starting with our mental health division. So I'll hand you over to Julie Atfield. Thank you.
Thank you, Julie Atfield, Director of Mental Health. I want to mainly focus the board's attention on out of area, and that's for patients who would be placed for their acute or psychiatric intensive care out of Nottinghamshire. Clearly, the chart shows a positive position, and we are sort of back towards normal performance for us, and in fact we only have 3 out of area patients at the moment, so that's in itself a significant improvement. However, pending winter, there is a sort of masked issue around large numbers of medically fit for discharge patients in mental health services for older people and adult mental health, and actually that does represent 20% of our bed stock, and actually whilst the figure looks quite flat in terms of delayed transfers of care for mental health services for older people, again that actually represents 15% of patients. So and those people are waiting mainly for health placements actually. So we have got some significant underlying issues, and one of them that's clearly increasing is people waiting for access to housing as well. So that is actually to the point where our commission step down, where people go when they to get some more extensive support around housing. That unit is actually full at the moment, and it has the turnover has deteriorated quite significantly. So the board are aware that this has been an issue, you know, for some time, and that we've had many multi-agency discharge events. So that's where everybody gets together in the system and we focus on sort of cases on a multi-agency basis to see whether we can progress people's care. The issue that has left us with is a lot of those events conclude with these people are very complex, but not actually a sort of productive outcome in many situations. So this continues to be a challenge to us, but not just to us, to the system. So what we are proposing to do now ahead of winter is to have probably an externally facilitated review of our Opal system triggers, because what we're finding ourselves is that the trust and actually the service are in quite an isolated position with this risk. So, you know, these delays exacerbate our difficulties with flow, clearly, and they also deteriorate our financial position if we need to use extra contracted beds and so forth, and it is clearly not in the best interests of our patients. So we are proposing to have a new fresh review of our Opal system triggers, because the current impact isn't really being felt sufficiently. So that's to cover out of area. I just mentioned a couple of other things. By and large, some of the variations in weighting are actually something that we have around seasonal variation, so particularly in relation to CAMS. And also we are again reviewing our IAPT performance around the BAME recovery target, which does appear to be related to people not attending appointments, so that's been investigated. So that's where I wanted to comment in terms of the operational performance around mental health.
Okay, thanks for that, Julie. And OPAL is the escalation framework, isn't it?
Yeah, operational escalation level. Yeah.
Thank you. So I've got a couple of questions. Paddy, please, and then Nigel. Paddy.
Paddy Tipping, Non-Executive Director. You can hear I've got builders in the house, so I'm sorry. Just on out of area placements, Julie, I mean, clearly there's an awful lot of work going on, but really this is a systems issue. And I just wonder how seriously the ICB are taking this and what leadership they're giving. You mentioned in particular housing, it's a local authority issue. Are we tying people in? You're talking about individual cases, but actually it's a system that we need to tackle. And then on a second point, we talked earlier on about dormitories and dormitory eradication and the improvement notice. It'd just be helpful if you could sketch in a little bit about the work that's going to be done between now and November.
Yes, so the first question is probably easier to answer than the second one. I think from an organisational perspective, the system needs to step up its response and its ambition. I think the system is too tolerant of this position, actually, and I look forward to, I suppose, the ICB refreshing its stance on how this is, you know, collectively managed. One of the things that we are doing, and Jan would comment on it if she was here, we are working with the system on a refresh of the mental health board, ICS mental health board, and I think it does sit front and centre there, and it is timely because our bed review is concluding, so it puts that firmly on the table for the ICB, whereas it can no longer sit with this organisation, you know, in terms of sovereignty, because it needs to be considered in its broader perspective. I think we're in a much better position now because, you know, we have got substantial evidence around the flow management and the information about patients. It's all live. We know who's waiting for accommodation and so forth, and we know about, for example, all the attempts that have been made to move people through. So as an organisation, we're positioned positively to respond to our, you know, to our own challenges around our accountability. But I think it, you know, I would advocate colleagues who do sit around the table to have this as a feature of the board's attention in the system. And also, I think it's going to be quite timely because there are some new mental health urgent care metrics nationally that are going to focus the ICB's attention as well. So I think it come at it from those directions. In terms of the eradicating dormitories, when patients move into Sherwood Oaks, will be 2 wards less with dormitories, which is obviously positive. That will leave us with 4 mental health services for older people's wards with dormitories. We have obviously got a plan in place to eradicate all of those remaining dormitories through the Millbrook business case and the Cherry ward business case, which are all in varying stages and overseen at F&P and will be coming to the board. But I think we'll probably discuss again and in perhaps the quality committee about how much further we want to act about the use of dormitories, because the building rectification is one thing, but it's how to satisfy ourselves and, you know, of course, the regulator in terms of our current practice around dormitories. I don't want to labour the point, but it's not straightforward, and with all the dormitories then remaining in mental health services for older people, if we don't use some of those dormitory beds, that will mean older people receiving care a long way from home and potentially in services that, you know, aren't directly overseen by us. So I think there's a careful consideration to be made about anything like that. I think I can talk a bit more about it.
Thanks, Julie. Paddy, does that give you?
So, I mean, I think eradicating dormitories has got to be a priority, and we need to put a plan together, and clearly there are going to be cost implications and other implications, but we need to move on it. On the first point on the out of area placements, I think you used the phrase, Julie, maybe I'm misquoting you, that the ICB needs to step up on this. And I just wonder what pressure collectively and individually we can put on the ICB to make. It's not just a problem here, it's a problem right across the landscape. And, you know, don't want to sound a bit cynical, but this is one of the issues that the ICB was set up to address.
So I'm just seeing, Paddy, that actually John Singfield has indicated that he could give a comment around some of that system engagement. So John, let's invite you in just to add a perspective on that.
Hi, John Singfield. I'm Deputy Director of Planning and Partnerships. I've not directly part of that, but there's some work underway at the moment about the development of a new integrated care strategy for the system. There's been a couple of workshops so far, and we've got to get an interim strategy developed by Christmas, roughly, and then the full strategy by next March. And I think part of the discussions that have been held so far is not to just restate and reaffirm some of the things that we already know we have to do, and more to talk about the role of the ICB and how the ICB can act as a kind of enabling and facilitative function to try and help shift some of this. You know, what's the collective power that we've got across the system, and the collective focus and drive that can be put there. So I think there's an opportunity to feed this kind of example in there, not specifically about that particular case, but I'm trying to bang the drum for that as much as I can in those workshops to make sure that voice is heard.
Thanks, John. And Paddy, we know that Anne Maria is sitting on the Integrated Care board as the mental health input there, and will have noted this. Julie, do you just want to respond back to Paddy on that before I bring Nigel in and then move us on? Julie?
Yeah, I just wanted to add, Paddy, one of the things that I think is going to be important in terms of the ICB and, you know, this issue is actually what, you know, the system is going to take. The first line is the system that has to govern itself, and the role of NHSIE changes. And in terms of this, that does pose a risk, I suppose, because, you know, the national mandate about out of area, if it's devolved into the ICB, is, you know, is an issue, and it is a risk for us. So all of, you know, all of the effect that we can bring to this issue is really important. But for me, it's probably an increased risk because of the change of those roles.
Yeah. Thanks, Julie.
Okay, thank you.
Nigel, please.
Thanks, Paul. Nigel Smith, Non-Executive Director. I think my question has changed as the previous discussion's gone on. Actually, a number of points that I was going to bring up have been covered, but I think it's fair to conclude really that the system hasn't yet got to grips with this problem, and it is a long-standing one that affects other parts of the country. I think that all that's understood. What I'm still not clear on, Julie, is from a trust point of view. Whether this is a capacity problem or a flow problem or both, and I suspect it's both. But reading through the commentary as to what's causing not just the out of area problem, but the use of non-NHT beds, which is normally private sector, which is a significant extra cost as well, is what we're actually going to do about it in the short term, because it is another wicked problem that's going to go on for months.
No, we don't wait. I mean, there are good practice in terms of getting it right first time, flow management that happens every day, several times a day. That is national good practice, and we're aligned with everybody else. And I think we've seen a considerable reduction in actually both out of area and non-NHT placement days as a consequence of I suppose the refocus on that. We knew we'd had that peak, and that was an unusual spike for us earlier in the year. So actually there is a change in sort of presentation and flow. The flow management, as I say, does continue. We do have 9 beds coming online, you know, as soon as we occupy Sherwood Oak, so that's a change. Okay. We've also put in place the Mill Lodge change as well, which is a direct impact on out of area. So it's something that we never stop grappling with. So in the winter funds, you know, we look as well for, you know, new sort of step down opportunities, new shared care approaches. We're trying to access the discharge to assess pathway. We never stop, Nigel.
Just quickly follow up.
Yeah, but I do want to say that we have 52 patients that are medically fit for discharge. So the solution is not all ours.
Could I just ask about on the non-NHT placement? It's a very straightforward question, really. Do commissioners, which is the ICB now, do they understand that is a significant cost to us and the system, and probably costing more than increasing the bed capacity ourselves?
Yes, they do know about the complete impact of that.
Okay, thank you.
I mean, the other systems, Nigel, treat that issue differently. So that's, you know, probably a conversation that we said we would have at the commissioning committee when the bed review's done. So the bed review is actually, that is an ICB trigger, I think, as well.
So I think the conclusion out of that helpful conversation is that we do need to use our levers into the system on this, and appreciating that already those are being used, but I think there's some clear board support for doing whatever is possible with those. Thanks, Julie. Alison, if you could steer us on, I think we've got 3 more bits to get through yet on the integrated performance report, so if you could steer us on, please.
Thank you, Chair. Alison Wild, Exec Director of Finance and Estates. We're moving on to our next operational division, so I'll hand over to Keely Sheldon for Community Health Services. Thank you.
Thank you, Alison. Keely Sheldon, Deputy Director for Community Health Services. So I'll take the paper as read. Just firstly, a highlight for the board's attention. We continue to deliver extremely well around community urgent response, achieving circa 20% above the national target of all calls coming in must be responded to in 2 hours, and delivering 92% and moving 94% of those patients onto the 2-day reablement to ensure we do everything possible to sustain that patient in their own environment and avoid admissions. Just a few challenges that the division are facing with regards to our performance. I'm sure you've heard it before at previous boards. One with regards to podiatry and surgical pathway. We continue around our recovery plan to achieve that 18-week wait. Just in addition to what's outlined in the paper, throughout September, we have responded to the national letter around Super September to support our elective recovery, and hope that will pace our recovery plan throughout September and achieve it quicker than we envisaged to do. With regards to other therapeutic pathways and waiting times, our community therapy services have obviously throughout COVID been deployed to support the urgent model of urgent community response and discharge to assess. And as Anne-Maria mentioned earlier, we have now secured investment for discharge to assess for those patients that need those reablement and rehabilitation packages being discharged from hospital, which will provide assurance, hopefully, that we've got the right capacity in the right place and free our community therapy colleagues to focus attention on community therapy interventions and hopefully recover that pathway within that 13-week wait programme. Just the last challenge I want to bring to the board's attention is around Lingsbar Hospital. I think we had a glimmer of hope that we'd reduce the length of stay last month, and unfortunately we've slipped back. The reasons for this slippage, I believe, is unfortunately all 3 wards was impacted through the end of July with COVID outbreaks, which hampered our flow out, especially for those patients needing discharge to care homes. And we're hopefully are rectifying that position and return to June's position quite swiftly over the next couple of months. Thank you.
Great, thanks Keely. Again, I'll just pause to see if anybody's got any questions or comments on those pieces. Manjit, let's come to you, please. Manjit.
Yeah, thank you. Manjit Darby, Non-Exec Director. I just want to pick up on the, I suppose it links to the conversation we've just had about delayed discharges and Julie's point about the 56 medically fit for discharge. With Lingsbar, and again, just thinking about my theme for this month's board is about our prep for winter, really, and just thinking about Lingsbar and our work that we've been doing, looking at the chart on page 58 of our papers, you know, kind of getting down back into the lower limits of our controls and being able to have really good flow feels like it's going to be really important moving into winter. I know that there's been specific reasons why we've had flow impacted in relation to COVID, but that's not going to go away, is it? So, you know, we're breaks for COVID and everything else moving into winter. How are we going to get any kind of flow going without the beds being silted up? Because whatever we're doing at the moment isn't sustaining our position, is it, in terms of getting people in and out again? Thanks, Manjit.
Keely.
Lovely. Thanks, Manjit. I think there's a couple of things that we've done from a transformational perspective. One, as we move ever closer to discharge to assess as opposed to assess to discharge, I'm hoping through the creation of the integrated hubs at each acute place will triage the relevant patients into pathway 2 beds. We know historically and throughout last winter we've utilised those beds because there hasn't been enough capacity either in home care and or pathway 1 provision. So I'm hoping that if we get the integrated hubs that triage the right patient need into those beds, in addition to having the right capacity through the investment of the pathway 1 provision at home, we can default to a position where we can try and move home first principles through the system and therefore only utilise the beds that we predict for 4% of our population coming out of the discharges from our acutes, where we're way over that at the minute through our utilisation of beds. And I think there's lots to learn from our acute trust colleagues to support flow. I don't think we've maxed our efforts with regards to criteria-led discharges to support that flow. And I know out in the system, equally, there's a home care task and finish group to make sure that our home care market is more resilient and sustainable. So we've got a discharge destination for those patients requiring a home care, which I think we've struggled at over the last couple of winters. So I'm hoping all those golden opportunities will get us in a better position of living within our bed footprint at Lings Bar.
Yeah, no, that's really helpful, Keely, and good to see that that work is happening. I mean, from a committee perspective, which committee is keeping track on this? Because I'm a bit confused about where that conversation is happening, because, you know, again, thinking about our flow as an organisation over winter is going to be critical to keeping us operational, but also making sure that we meet the needs of the most poorly patients. So kind of where are we tracking it? So is it in the quality committee?
Internally, I think we are tracking that through CHS assurance boards on a monthly basis that feeds out into the performance dialogue and through to this meeting here. I also believe there's those dialogues out in the system. We've got the ICS discharge board where those metrics are discussed and monitored, and how Notts Healthcare plays its part in the system delivering the overarching flow with regards to complex discharge.
So I think on that piece, Manjit, let's perhaps just put a marker out and ask Anne-Maria and the execs just to work out where's the best place to be getting some focus on that. Alison, I think you might be wanting to give us a bit of clarity around it.
Yeah. Thank you, Paul. Alison Wild, Exec Director of Finance and Estates. So the board will be aware that we are planning to change the content of our subcommittees. So Finance and Planning Committee will become Finance and Performance, and Strategy will become Strategy and Planning. So going forward, Finance and Performance Committee, which will be established next month, will start doing some of these deep dives into the performance of some particular areas, and I think this is one that we would do that focus on. Currently, the integrated performance report comes directly to board because of timing issues and getting the most timely information to our public board as soon as we can. So I think that change in the subcommittee structure will address where that performance can be discussed. Thank you.
Thanks for that. And Alison, let's get you to steer us on into the next part of the integrated performance report, please.
Thank you. We're just moving on to our final operational division and forensic services, and Sue Elcock. Thank you.
Hi, Sue Elcock, Forensic Director and Medical Director. So in terms of what I want to draw the board's attention to, the occupancy figures are there. That remains fairly static. So I'm going to move on from that. The two big issues which we've already talked about, the one in particular detail is about our staffing levels, particularly in terms of availability, which then encompasses issues such as our sickness levels. And as you'll see from the figures here, our sickness has gone up quite significantly in the last quarter, which we are looking at to understand the reasons. We do know that it's not COVID. We do know that one of our highest factors is stress and anxiety. And I think we've talked about, even at this morning's presentation to the CQC, about burnout. And obviously Jen's already talked to you at some length about the wellbeing offer being ramped up, which I really like that sort of word. I think that is what the offer is. So just wanted to really draw your attention to that. We know that Rampton and Arnold Lodge in particular, I've been reporting to board, have been high in terms of vacancies and sickness for some time. We've had really good recruitment, so it's not in this quarter in terms of this report, but so for example this morning we've had our highest number of people at our Rampton induction, and the same at Arnold Lodge is planned. Watford is starting to creep up, which we're again just having a look at and understanding. Earlier on, I think it was Paddy and Nigel talked about the impact of this upon patients, and Tabitha talked about incidents which we are monitoring and looking to triangulate to look at the impact. One of the things that we've incorporated now into the board report is for absolute honest and open transparency is one of the impacts of one of our contingencies, which is where we're not able to either unlock bedrooms or we're having to use confinement in certain times during the day because of staffing, and that's that's part of our latest sort of levels of contingency, if I can say, done towards the end. So we're reporting that to board, and then in the actual IPR section there's the actual detail, because I think it's important that you can see more about the actual impact. So I think that's page, just whizzed through, I think it's 62 in the report, so you can see, for example, where it's longer periods of time or where it's one patient for I think it's 6 minutes, the one example. But I think we wanted to be absolutely open with everybody to see that, and to say that we do that at the absolute sort of last resort, and we are talking with the patients. The other thing that's important for people to know is that we rotate that round, so we aren't impacting upon one particular patient group or patients, for example, in long-term segregation or anything like that. We've been really clear to make it spread across. So I just wanted to draw board's attention, because it's the first time you will have seen that data in the IPR.
Thanks, Sue. It's helpful to put a bit of a spotlight on that additional information there. So I'll pause to see if there are any questions or comments. Again, I think you've done a good job in triangulating with some of the earlier conversations that we've had there. Nigel, please.
Thank you, Paul. Just a comment really. So the first time you've made me aware of a link in this direction. What you said, I think, was that the impact of the number of vacancies we're carrying is having an effect on staff stress and anxiety, because there simply aren't enough of them to cover, and that in itself is driving up the sick absence. And I hadn't seen it quite that way before. Have I clocked that correctly? Is that the way you see it working? The more short we are of staff, the higher the sick absence goes, which of course increases the shortages of staff still further.
I don't know if the stats say it as bluntly. I think that's the sense we're getting from staff, and in the sense of their level of resilience, tolerance, availability. They've gone above and beyond now for so long, they've almost can't do that, and we can't keep expecting them to, which I think Jen wants to come in, but that's part of the issue about really maximising the bank, etc. Options. So yeah, but it's not a fact, if you know what I mean, so to speak.
Jen, did you want to come in on that?
Yeah, Jen Gwyver, Exec Director of People and Culture. So just to reference back, Nigel, to the sickness rate on the IPR, we've got this unusual statistic for the latest wave that the absence went up, but not recorded as COVID. Not exclusively, but a large amount of that was non-COVID absence. And that's what I said. I think we need to see how that pans out over a couple of months rather than act on 1 month's data. But I think that one hypothesis is what Sue's saying, that people are that wave, some of the absence we saw was people who were burnt out, tired, didn't necessarily have COVID, or perhaps their family had COVID. We don't know. It's a bit of a watch and wait, but that I think that July sickness stat is quite interesting in terms of that longer term COVID impact.
All right, thanks. Okay, shall we move on to the final part of the integrated performance report, and then I'm going to propose we take a short break before moving on. Alison, please.
Thank you. Alison Wild, Exec Director of Finance and Estates. So I'm just going to give you a brief summary of the finances as at month 4. A lot of this we may have covered in previous discussions, but as at month 4, our year-to-date plan is 43k surplus against plan, and we're forecasting a break-even. In terms of our financial improvement programme, the plan was to deliver £5 million as at month 4, and 4.5 million is being delivered, again forecast to achieve at the year end. Capital 2 million under plan, but that's timing only, and we are also expected to be able to catch that up before the year end. Having said that, page 64 of the papers, there are some significant risks in there, and there are some significant variances in that. I think we've covered off in terms of the pay underspends and offsets on agency in all the previous discussions, and the finances are following that pattern. and there is an overspend on out of area beds, which we've just discussed in terms of mental health services. The risks in that are that we have agency expenditure which is over cap, and we're currently forecasting £1.3 million over cap, and there is a national drive for us to reduce that. As Jen said earlier, that drive isn't necessarily about stopping agency, it's about using on framework agencies, about trying to encourage use of our bank and moving the agency staff onto bank wherever possible. So there's lots of work and a group set up to try and address our agency staff. That is also being looked at as a system so that we aren't competing with each other. So there are plans in place to try and reduce that agency. Two things that haven't been highlighted in the rest of the performance report is our income for cost per case for Hopewood, children's adolescent unit beds and eating disorder beds are under plan due to some closures of wards because of high acuity of patients and safety reasons, and I think that's the same across the region. And the other one is that the improving access into psychological therapist services is under plan for income for reasons that we think are about staff leaving, etc. So is not on target where we need to be. However, it was under income forecast prior to the decision to close the services. So inflationary pressures are also a risk to us. Energy, food provision and contract increases, we're monitoring those on a weekly basis, and we continue to build that into the position in terms of anything that we know about. Vaccination and COVID expenditure as a system is under pressure and isn't fully funded, and there is an ask that we try and reduce COVID and vaccination expenditure. So that's under continual review internally and as a system. In terms of moving forward, our financial improvement plans, we have actually identified full schemes and we'll be reporting that to Finance and Planning Committee at the end of the month. However, only 39% of that identified financial improvement plans are recurrent, so there are a lot of non-recurrent achievements within that, mainly due to the underspends in staffing and our inability to recruit, so are fortuitous rather than planned. I'll pause there in case there are any questions. Thank you.
Yeah, we've got a couple of questions. I'm going to come to Fiona first because we've not heard from you, Fiona. So let's bring you in first and then Nigel. Fiona.
Thank you there, Chair. Fiona Daniel, Non-Executive Director, and this may have also been covered or discussed actually previously, but I just want to pick up on something on page 64. And it's just regarding a statement that we have here that we say pay is 4.2 million under plan. This is due to leavers since March and recruitment assumptions not coming to fruition. So my question actually is, you know, if these recruitment assumptions are not coming to fruition, do we need to then look at and review the assumptions that we've been making and to make sure that the assumptions are actually probably a little bit more accurate as near as we can get, bearing in mind obviously all the conversations that we've had prior as well?
Yeah, that's a fair question. Thank you, Fiona. So yes, you're absolutely right. We set our plan at a point in time and we have to nationally submit that, and once it's actually submitted there is little, if any, chance to review that plan and resubmit. The main assumptions on that pay expenditure was in the forensic division, where they were particularly low in staffing at the point of setting the plan, and I think we reviewed that and challenged that on several occasions, but the plan was based on getting back up to the previous year's staffing levels, which I think everybody accepted was a reasonable assumption just to get back to where we were. So yes, I accept that, but unfortunately we're not able to resubmit that plan. What that is doing, though, in terms of our financial assumptions going forward, is helping us address the out of area bed spend that we also weren't assuming in the plan. So yeah, I think there are lessons to be learned in future years planning, that we challenge each other to actually get those assumptions as close to reality as possible. But it's based on known information at that point in time. But yeah, you're absolutely right. Good challenge.
Thank you.
Thanks. And Nigel, please.
Thanks, Paul. Nigel Smith, Non-Executive Director. I've got a couple of questions actually, Alice. On the face of it, our financial performance is fine, isn't it? Because we're achieving break even, but the method by which we're achieving it is giving me some discomfort, and it links directly to the previous conversations, because a large part of our savings against the plan, which Fiona's referred to, is a result of our vacancy levels, which we'd actually prefer not to have. And if we do fill those vacancies, we'll therefore be over plan from a financial point of view. So we need a financial improvement plan in terms of efficiency improvements that's going to help us pay for that recruitment. Otherwise we'll have a financial problem in addition to all the other issues that we've discussed. And I think this really comes out in the table on page 65 or page 39 of the IPR, where you talk about achieving the financial improvement plan 20 million, 12.4 million of it is non-recurrent, which I assume is where these vacancies are sitting. Now I'll put aside my discomfort about regarding vacancies as a financial improvement. I understand that's the way the NHS classifies it. But what have you assumed in doing your forecasts about filling these vacancies? It looks to me like you've assumed that we won't fill these vacancies for the rest of the year, and that's why that figure 12.4 million is sitting in that report. Am I right?
No, it's a little bit more complex than that.
Okay.
Thank you, Nigel. So each of our divisions and accountants that support those divisions look at each service individually. They consider, they talk to the operational managers about their recruitment plans, how many they have appointed, when they think they'll be in post. So it is absolutely done on a post by post basis, and we also look at the history and whether we've been able to do that going forward. So it's quite technical how we do that, and it is done very well. It will be very different across the whole trust, but probably that's something that we could pick up in Finance and Planning Committee about our assumptions and how we've got to that forecast, if that would help.
Just to give the board a sense of that, though, Alison, you are assuming that at least a proportion of our current vacancies are going to get filled. Is that right?
Yes, that's right. Yeah, it will only be a small proportion based upon the knowledge that we have, but it will only be that. Yeah.
Okay, and of the, just finally, Paul, if you don't mind, on the FIP achieved year to date, I think it's 4.5 million, isn't it? Year to date.
Yeah.
How much of that is due to vacancies? Is it roughly 2.8 million as indicated in that table, or is it more complex than that?
I need to get back to you on that. I don't know the answer. I would be guessing at the answer, so I will absolutely get back to the board and confirm that how much of that is recurrent and how much is non-recurrent. Okay, thank you. Thanks, Paul.
Thanks very much. Sounds like there's further conversations that the Finance Committee can have on this as well, just to ensure that scrutiny. Thanks very much, Alison. As ever, it's important that we spend time on the Integrated Performance Report. And as I mentioned, it did feel like we were drawing the integrated piece perhaps more closely than we do on some occasions, which I appreciate. What I'm going to suggest is that we take a break until 11:10, and just to flag that I'm going to suggest that we take item 12 as our next item, because I know that Yolanda has to leave, so I'll take that one at 11:10, please. So see you back in 10 or 11 minutes. Thank you. Okay, I think we're ready to restart, please. So, as I said just before the break, if we could go to item 12, please, the staff awards summary. And Yolanda, over to you, please. You're on mute, Yolanda.
There's always one, Paul. Sorry, it was me. Thank you, Paul. Good morning, everyone. Yolanda Martin, Associate Director of Communications and Engagement. So prior to April 2021, the organisation didn't necessarily promote awards internally in the organisation, but the communications team developed a forward planner, and we took a proactive approach to nominating staff and colleagues across the organisation and volunteers in awards, both local, regional and national. So the paper today, taken as read, is an annual summary that demonstrates that in the year up to March 2022, individuals and teams across the organisation were shortlisted for 18 awards. They were highly commended in one, they came second in another, and we won 9 awards, which is a fabulous achievement. The quarterly summary that's also attached is from April to June, which maintains that success in terms of 4 shortlisted and 7 winners. So we're doing even better so far, fingers crossed, this time around. It's a really positive trend when you bear in mind that the award season doesn't really come into play until around about now in the autumn. As part of our work to promote the organisation as a great place to work, we've also developed a Celebrating Success area on our website where we put all the award nominations and other successes in a simple, easy to read format. That page also links directly to our recruitment microsite, which we also created at around the same sort of time. We also promote our awards successes on our social media, within our internal staff updates and our media releases. So we've also had a number of media articles that have been printed in national and regional media talking about our success. Unfortunately, prior to April 2021, we don't have any data for how successful we were before, but the feedback that we get from colleagues across the organisation and from the communications team is that promoting the awards and helping colleagues to be aware of what awards are open and the closing date, regularly reminding people and helping people with the awards is really paying dividends in terms of the success for the organisation. And it really does promote our staff as award winners in every sense of the word. So happy to take any questions.
Great, thanks Yolanda. It's really good to see this report and to see the successes that our staff have been having. I'll just pause to see if anybody else wants to make a comment. I've got one other thing I wanted to say. I think the piece I was just going to add, Yolanda, is to link it back to some of our earlier conversation about the importance of us being an attractive place to work. And actually, one of the knock-ons of being seen to perform really, really well in regional and national awards is that people who don't know the trust start to see us, and they see us a place that I want to work at a place that can win like this. Whilst it's great recognition for our current staff, I think it reflects really well on the organisation. So thanks for that. And what frequency will we be getting to see this at the board? What's the plan?
If you would like, you could have it as a quarterly, and then I'll still do the annual summary. So the plan is to bring this quarterly.
Yeah, I think that would be really helpful if colleagues can make a note of that, because I think it's a useful spotlight for us to put on some of the achievements of our staff.
Thank you, Paul.
Great. Thanks very much for that, Yolanda. In which case, we'll go now to item 10, the Security Services Quarterly Report. Sue.
Thanks, Paul. Sue Alcock, Forensic Director and Medical Director in the Trust. So I'll take the report as read, noting for the board that it's a mandated report that comes quarterly. It's got 2 functions. One is to assure the board that we're compliant with the security directions, and the second is to request approval from the board for a further 3 months of the use of nighttime confinement across our high secure hospital Rampton. So I'm not going to go into the detail of there. I think just to pick out that previously we've talked about staffing already in some level of detail. As you'd expect, we've had issues in terms of the impact on staff training, and we've got a recovery plan in place for the different elements, in particular around security training, obviously given the importance of that. So to be fair, I was going to just draw the board's attention to that really, and then ask for approval for a further 3 months of nighttime confinement.
Great, thanks, Sue. We'll pause before we get to the approval point, just to see if there's anything anybody wants to pick out from the report. It's worth saying to anybody who's observing the meeting that this is a standard paper that comes to the board every quarter. And as Sue said, it's about demonstrating that we are both meeting statutory requirements and also as a board taking a moment to make that recommitment. So I'm not seeing any further comments or questions. So we're asked to authorise the continuation of night confinement under the statutory regulation for all Rampton Hospital wards for a further 3 months duration. So can I just get an indication from colleagues if you're content to agree that, please? Thank you. Right. In which case, let's move to item 11, and we're still with you, Sue, the research annual report, please.
Thank you. So I'll dwell a little bit longer on this. So this is the annual report. I'll highlight to the board, I think, the importance and the reason we've gone into quite a lot of detail to help everyone understand the types of research that we're involved with, and also some of the organisations that we host or that we're partners within. This report has previously been well received by the board in terms of improving its level of understanding. It's one of our BAF risk areas, so in terms of assuring the board of, I suppose, the significant amount of research is one of the big things I need to get sort of showcased in a sense. So without going into it in full detail, some of the things just to highlight, I think, are the range. We're particularly involved in a lot of mental health research, and one of the things that we've been talking about is how we make sure that we also focus on physical health research, and so that's one of our things that we're considering at the moment. We've had a couple of clinical academics that are ACPs, sorry, I'm doing mention now as well, AHPs, allied health professionals, in post in the trust, and we're just learning from the positives that they've brought, and they're also award winners, just to carry on that theme. And we're currently working out what our nursing and AHP strategy moving forwards in terms of academics in the trust. We have a number of medical and we have a number of psychology academics, and we're looking at how we broaden that. So that's in the sort of early pages. We've then got information in terms of the IMH, which is the Institute of Mental Health. So that is a partnership between ourselves as the trust and the University of Nottingham that has over the last decade been incredibly successful in terms of its level of research. It's internationally renowned, and there's information from IMH colleagues who I'd like to thank for assisting putting in the detail there. We've got Applied Research Centre, which is the ARC, then Detailed, which again we host. That's recently had a review. It's incredibly, again, successful, and that's about putting research into practice. And there's, again, thanks to colleagues for their input that they've given in terms of what they've been able to achieve over the last year. And then MindTech, which we also host. And again, there's information there for colleagues. So we are an incredibly research active trust, I suppose, is the message I want to get across to colleagues from that. So I'll stop there.
Thanks very much, Sue. And let's just open that up for any comments or questions. So I'll start with Sue, if I can. Sue Sunderland.
Sue Sunderland, Non-Exec Director. Thanks for that, Sue. It was interesting, my first read of these. I just was interested in those studies that we sponsor. and that actually reading it is suggested that we weren't necessarily participating in all of the studies that we sponsor, and I just wondered how we selected studies that we did go for sponsoring, and why they wouldn't be ones that we were then actively participating in.
Because it's because the IMH is a partnership between ourselves and university, but we, as the in terms of governance, sponsor a lot of the studies. The university, there will be things that sometimes aren't particularly fully relevant, or we don't have that clinical service, but we would still be the sponsor in terms of the governance arrangements. So I won't go into detail about the whole process. I'd probably need to get a technical expert, if I'm honest, to explain it, but we've got robust governance around what we do. We've got SOPs, so we've got standard operating procedures in place for all of the issues in terms of how sponsorship works.
So we could easily be sponsoring something which isn't directly relevant to our areas of service.
Yeah, there's usually some relevance, but whether we would have the actual clinical services that could engage in the study might not be fully. Yeah.
Okay, thanks.
And then if we go to Nigel and then to Paddy. Nigel.
Thanks, Paul. So Sunderland has asked my question actually there, so we're on the same wavelength. I'll just limit myself to a comment then in terms of the importance of research, which Sue has emphasised. Going back to the previous discussion on recruitment, it's really important for the reputation of the organisation to have a strong research function, because it, as I recall, it's particularly important in attracting clinical staff, particularly doctors. So I welcome the report too, and I think it's it enhances the reputation of the trust. So keep up the good work.
Thank you.
Thanks, Nigel. Paddy.
So this was incredibly rich, and I enjoyed reading it a lot. But I've done a lot on research over the years, and there's always a bit of tension between what academics and clinicians and practitioners want to do and what the needs of the organisation actually are. And I wondered if you just comment on that. And I wondered whether you might just say a little bit about the Institute for Mental Health. I get the impression, perhaps I'm wrong, that the university take the lead on this, and I'd want to be assured that, you know, we're an equal and active partner.
Yeah, so if I take the second first about the IMH, so the Institute of Mental Health has a board that oversees its running. It's co-chaired by myself and a university vice-chancellor. It's got equal representation. I would say that the trust fully participates and sees itself as a very strong partnership with the university. My experience to date over the last couple of years is of a really respectful partnership that runs the IMH. So I'm very confident on that. In terms of the tension, I don't, compared to perhaps previous experiences or others' experiences, I don't feel that quite so much with the IMH, because our academics that work in the IMH pretty much also do a lot of clinical work and do clinical roles, and generally they are researching in the clinical areas that they come from, actually, in their specialties. So actually it works quite well. Some of our newer academics, so we've created some newer sort of grow our own pipeline of academics approach that we're just starting, very small scale, a couple of early posts, and again they're embedded in services, and their interests are, we've guided, and their interests and why they've been employed almost is because their interest is in our clinical sort of services they're going to be working in. So I don't feel that tension, actually.
Right. Thanks for that. Thanks for that, Sue. And I'll just add something which I think I do say every year, actually, Sue, is just to whilst absolutely supporting this report and the comments from colleagues, I think for me there's something about also recognising this does pick up what I kind of term the more formal academic research, and that there is also stuff that we do as a trust, which is perhaps more around user experience, engagement, of which within that there are elements of research, and I'm not sure we quite capture that piece, and I know it is quite different from the more formal pieces that you describe here, but it's just to put a flag out there that there is stuff that we do which might come under a looser banner of research, that is outside of the more formal academic bit.
Okay, I'll have a think about how we and where we incorporate that.
Thanks, that'll be helpful. Great, I'm not seeing any other comments, so I think you can take that as landing well with us. Again, Sue, let's move to item 13 if we can, which is about review and learning from patient, staff, carer stories. I think it's our first 6-monthly update on this, and over to you, Tabitha, please.
Thank you, Chair. Tabitha Darman, Interim Executive Director of Nursing, AHPs and Quality. In the previous board, it was asked to sort of say we hear a lot of stories to board and would like to know what learning we take from those stories that we hear. So this paper is here. I'm not going to go through it. I'll take it as read. It's here to just give assurance that we've reviewed thematically 6 stories from both staff, patients and carers. And there are some actions within the report that we have taken. But my point is to just sort of say we're giving assurance that we do listen, we act, we engage, and we try to continuously improve. So I will take any questions.
Thanks very much, Tabitha. I would say personally, I really welcome this. I think it's something that is an important one for us, to just be able to demonstrate that we go beyond just hearing the story at a given meeting. Let's take a couple of comments. Fiona, start us off, please.
Thank you, Paul, although you've taken my line. So it's Fiona Daniel, non-executive director. It was just to say the same thing. I was so pleased to actually see this in amongst all the papers, but I think it's just so important that when we have these stories that we do demonstrate that, you know, these aren't wasted stories, that we are absolutely listening to them and taking action, and also sharing, you know, best practice, because there's such good richness in a lot of the things that we hear that can be shared across the trust in terms of, you know, great learns and, you know, just to have that whole visibility across these stories. So I just wanted to say thanks to everyone really in taking the actions and consistently and continuously learning and improving and enhancing what we do. So yeah, that was it really. Thank you. It was more of a comment, no question. So thank you.
Thanks, Fiona. If we go to Sue Sunderland, please.
Very similar vein to the comments that Fiona's just made. I think it's brilliant to hear from the people at each meeting, but actually it's more important that we've actually can demonstrate that we've listened to what they've said to us and gone away and reflected on that and seen if there's anything that needs to change. So it was really just an echo of what Fiona said. Thanks very much for bringing that.
Thanks. And Carolyn, please.
Thank you, Carolyn, my non-exec director. Tabitha, thank you. I echo everybody else's comments. It's really good to see this coming through. I think looking at the balance of stories, it's good that we've managed to get those across different divisions. I really like the little assessment of sentiment in there, which helps us to understand the approach, I suppose, that the patient made. Quite a lot of the stories that we've had over the last, well, in the time we've been having patient stories are positive stories. And I guess there's always things that we can learn from those and share with other areas. But I think the richness for us is where we get things wrong sometimes. So I'm just wondering whether as we go forward, whether we can link this up more with perhaps areas of complaint and actually try and target stories across different services where we haven't got things right, and what we've done as a consequence of that, to just try and test ourselves a little bit more really about what it is that we are doing to improve services. But it's great to see this report coming through now. Thank you.
Thank you, and we'll try and triangulate. Thank you very much, Caroline.
Yeah, I think it's a good point, Carol, in that you know, our intent is not just to have those good news stories, but some of the stories we learn most from are ones where people are saying, you know what, for some of this we didn't get it right. I think that that's important for us to be having those conversations and listening and learning from those as well. Great. Thank you very much. Let's then move ourselves on to the Board Assurance Framework and Significant Risks Report. Rebecca, over to you, please.
Thank you, Paul. So my name is Rebecca Allen and I'm the Deputy Director of Corporate Affairs. So this paper is presented to Board quarterly and provides assurance to the Board around the risk management treatments for each of the strategic priorities of the Trust. The paper itself sets out the process by which each of these risks is reviewed and managed, describing how each has an exec lead and goes to an executive committee for assurance. The Board Assurance Framework, the BAF, is reviewed each month also at the Risk Committee for additional scrutiny. So in this report, the exec summary highlights a number of key points. I'll just pick out a few. There is one new strategic risk identified within the financial stability, which is SR5, and this relates to the financial improvement plan, which I think has been covered within the IPR discussions. The Audit Committee reviewed the BAF and provided positive assurance with 2 actions highlighted within the report required to gain further assurance. The report reflects the work that has been undertaken over the last quarter, and to note particularly the change in language for SR1, which has been updated to reflect a more modern and a respectful terminology that is in line with the Trust values. Just to reiterate, this has not resulted in any change to the risk scores, only the descriptions of those risks. And Jen might want to say more on that, but happy to take any questions on that. Thank you.
Great, thanks, Rebecca. Let's pause and see if there are any questions or comments. I think you've clarified what the purpose of those changes really clearly for us there. So I'll just pause to see if there are any comments or questions to come through. Okay, I'm not getting anything coming through. Colleagues, we're asked to give approval to this report and paper. So can I ask you to give me an indication, please, of whether or not you approve the paper? Great, thank you. Getting support for that, Rebecca. So in which case, let's move on, if we can, please, to the reports from subcommittees. As usual, colleagues, if we take these as read, if there's any specific piece to highlight, please do bring that out for us. And if we can go first to item 15, the highlight report from the Finance Committee, Nigel.
Thanks, Paul. We've got a bit of a timing thing going on here. The meeting that's referenced in the papers actually took place just before the August board meeting, so we are about a month out of date, and obviously with financial performance things change. I think it's fair to say we've covered adequately the income and expenditure performance in terms of our break-even aspiration and performance so far, so I'll not comment on income and expenditure. Capital is worth a word. We have got a challenge on capital at the moment, and it's not because of our lack of cash, as we all know. It's because of the capital planning system that imposes constraints on our ability to spend our own money. And we have planned to spend a bit more than the system wants us to do. And when we took the paper on this a month ago, there's still a level of overcommitment in our plans, but that level of overcommitment is reducing. It may well have reduced even further by now, but I think the board is fully aware of the reasons why we're doing this. A combination of inflation, backlog maintenance and health and safety pressures, including eradication of dormitories, is pricing demands on the trust to spend more on capital than the system wants us to do. So there is a bit of a dilemma there. We are spending our capital quite well actually so far this year. It's a normal thing in capital expenditure to have significant underspends, but we've already spent 8 million. So things are progressing well, but we are expecting later in the year to come up against some pressures of the capital expenditure limit that the system has imposed. I'll take any questions, Paul. Anything else I want to particularly highlight?
Great, thanks very much, Nigel. I think you focused in on the key piece there for us, and I'm not seeing any questions coming through, in which case let's go to the Quality and Mental Health Legislation Committee. Carolyn, please.
Yeah, thank you, Chair. Carolyn White, Non-Exec Director, Chair of the Quality and Mental Health Legislation Committee. We met last on the 16th of August. No concerns to escalate to the board. I think just worthy of note, there was a broad range of papers that we discussed, but was the health inequalities work that is being led by Dr. Chris Packham, a really good update to the committee in terms of the work of that. I mean, it's still in its infancy, but promises to be a really good piece of work, and that team will continue to come back and report to us. We also received 3 annual reports, suicide prevention, which we've heard already this morning, the really important work going on across the trust related to suicide prevention. A great report from the involvement, experience and volunteering team, who, despite all of the challenges over the last year in terms of lockdown and not able to get out and about as much, I've done some absolutely sterling work with volunteers and with patient engagement, and a good overview of the work of the Quality Operational Group, which has really embedded in the last year and improved its governance processes. So overall, a really good meeting. Happy to take any questions if there are any.
Great, thanks very much, Carolyn. Not seeing anybody wanting to come in on that. So if we just go to item 17, the commissioning committee, I think this one will be short and sweet, Manjit.
Yes, just to note on the record, Chair, that the meeting had to be cancelled at short notice and will be reconvened in a couple of weeks. So we'll bring an update to the next board meeting.
That's great. Thank you very much. Our next item is it's something which is now become a standard thing for us, is to just take a video in public that showcases one of our services. Julie, do you just want to give a headline introduction to this one?
Yes, of course. Julie Atfield, Executive Director of Mental Health. The Trust launched the Therapeutic Intervention Service, which is the focus of this video, on the 1st of April. And it's actually to provide specific evidence-based treatments for people with dementia who are over 65 generally, and for also people over 65 who have a mild to moderate mental health difficulty. The service covers the whole of Nottinghamshire, and it's sort of place-based delivery really. It's a multidisciplinary team focus, and there's a complement of 16 staff delivering the service now, and it launched with its psychoeducational dementia groups for people with newly diagnosed dementia, and the group's run for 8 consecutive weeks. So it's part of that step between primary care, prevention, and also to support carers. So the courses are very sort of evidence-based designed, with a focus on outcomes, and it rather is taking some of the methodology from IAP to understand its outcomes. And the service has also launched its newest group, which is around anxiety management. So really pleased to sort of hand over to the video and to colleagues.
Great. So Roshane, if you can work your magic, please.
So, as I say, we're the Therapeutic Intervention Service, or TIS, and we've got multiple bases. Because we're county-wide, we have got bases at the Lingsbar Hospital, Highbury Hospital, and we're currently renting facilities in the north until we get a permanent base. So therefore we've got a base at Mansfield Community Hospital, Byron House at Newark, and we're hoping soon to have another base at the Lamas Health and Wellbeing Village in Kirkby. So we're a brand new service. We launched in April of this year, and our objective is to provide therapeutic group work and educational group work to people within MESOP. So that includes people who've got a diagnosis of dementia of any age, so young onset dementia, and individuals that have come through MAS, or the Memory Assessment Service. And then we also provide therapeutic group work for people with mental health conditions aged 65 plus. So generally that will be somebody with anxiety, depression, and later we'll be providing services for people with a personality disorder. We're actually struggling currently because it's the psychologists that we employ that write the group programmes, and both of our psychologists have gone on mat leave. So we've been trying to recruit into their posts, and that's a struggle. Another bit of a challenge has been venues, so especially in Mid-Knots, eventually we're going to be moving into Millbrook, but Millbrook's not yet ready for us. So we're having to rely on the goodwill of other hospital trusts and community venues, which has actually worked out fantastic. But of course it was a little bit of a wobble for us in the early days. I think I'm really quite proud of the service generally. So the staff that we've got have been amazing. They're all really, really dynamic. They're all doing something quite new. There's lots of different types of staff that's come together. So we've got very young staff to staff who are a bit older. We've got assistant psychologists, occupational therapists, nurses, family peer support workers, and they're all really coming together and really working hard to provide a seamless service. So that's really nice to see. Some staff have been in the trust for years, some staff are fresh out of uni. So that blend has been lovely. And I think also watching the service develop from scratch. You know, I remember us being sat around a table in November of last year and having to start from scratch building this service. To see us sitting around a table almost scratching our heads, where do we go? So that now we're delivering probably about 8 or 9, maybe more, 10 groups a week. We've got nearly 80 people on our books. It's like, wow, we're all really proud of everything we've achieved. So we're going to expand and keep on expanding really. And the next group that we're going to launch is a group for people with depression. So it's underpinned by something called compassion focused therapy. And then the world's our oyster really. We've talked about stabilisation groups. We've talked about delivering mindfulness sessions to people. We are hoping to work more closely with people who've got a diagnosis of a personality disorder. So wherever there's a need, we're hoping that we can provide something for those individuals. We can offer something for everybody. We're a brand new service, so we're absolutely up to date. All of our products that we deliver, if you like, are all evidence-based, contemporary. The staff are enthusiastic, bubbly. The feedback that we've had so far has been great. We've not had a lot of feedback yet because we're only just reaching the end of our first group sessions, but the bits and bobs that we have been great. The ops manager sat in on some of the sessions and he thought it was really, really well that the staff engaged really well with the patients. They've got good information to deliver. The presentations were set up well. So yeah, so all the feedback's been great. So we're really pleased with that.
Great. As ever with these showcases, it's just so good just to take a moment to focus in on a service. Julie, can I just check? Is there anything you wanted to say to wrap that up?
Yeah, I just wanted to sort of mention that we weren't renting premises. It's our own premises in different places, but also that this is part of the transformation from what was purely a sort of organic sort of support service and treatment service in the community, and actually changing it and developing it and bringing a broader therapeutic offer is online with the investment in the long-term plan, and yeah, it's recurrent investment. It also gives us an opportunity, as you can tell, to deliver something at high volume that's locally accessible. So
great, thanks very much. I know we're not opening it up for discussion, but always good to see these showcases. So I've not had any other urgent business notified. So our final item is just to review the meeting. Can I just get a couple of reflections from colleagues about today's public board meeting, please? I would like to hear a couple of voices if I can, please. Nigel, step forward.
Yeah, Paul, it was a good meeting. I enjoyed the discussion about some operational performance issues. I did wonder at one point if we were getting into too much detail for a board meeting, but I think we avoided that. And as usual, you've landed us on schedule. So I think it was a good mix of strategic and a little bit of detail where we thought we had issues to solve.
Thanks very much. Let's go to Jen, please.
So I was just going to reiterate the comment about the everything being interlinked. So I think it was good to see Tabitha taking a number of questions around the people agenda that we were well connected on. So that's really good to see the connection across portfolio areas, I thought.
Thank you. Sue S, please.
Yep, very similar theme from myself. It felt like it was a really positive discussion on key issues that are really affecting us and actually underpin a lot of other consequences that we're seeing in the way in which we're able to deliver services, and particularly picking out some of those workforce issues that we're struggling with and what we're trying to do about it. Felt like it was a very good discussion and rounded with some depth.
Great, thank you. And Trevor, please.
Yeah, thanks, Paul. I was particularly encouraged about the sharing, spinning off of the Oscars, and then Yolanda sharing some of the stories of successes of our teams and our people. That it's a tough environment in the trust, it's a tough environment in the NHS, and making sure that we recognise and celebrate how hard and how diligent and committed our teams are and our people are. I think it's a really important part of the agenda, Paul, and we should never lose sight of. Without that support, it's pretty tough. So it's a nice balance between the business side and the people side today. Really enjoyed it. Thank you.
Great, thank you. Carolyn, please.
Thanks. Yeah, Paul, I think I'm just reflecting on the board assurance framework, and if we look back at the agenda and some of the items that we've had quite a lot of detailed discussion on, those are the things that feature in terms of our high risk issues in terms of the BAF. So I feel like we're doing the work that we should be doing and taking the focus on in the right areas.
Great, thank you. And just as for a final comment, Anne Maria, do you just want to reflect? I know it's your first one sat in the chief executive chair.
In the hot seat. Thank you, Paul. Yeah, I do feel that the executives have worked really hard to ensure we have triangulation amongst ourselves as well before we come to the board. So it's not ad hoc. It's a conversation that's already been had and given some thought to as well. And I think that we're starting to focus on the right things. I was really, really happy to see the board stories because, as everybody has said, it's not something we've brought to the board before. It's the first time we've done a bit of an analysis on the work. We were already doing work on board stories. It wasn't just hearing a story and not doing anything with it. We actually were doing things behind the scenes, but actually it's good to be explicit and come out and say this is the work we've done with these stories, and we haven't just listened to it and thought, oh, that was a nice story and let me just take it away and not do anything with it, because we have done something. So I felt that there was a couple of things in there that were on the newer side that actually gave more depth to the conversations, but also shows the learning that we have as a board, because that's what this organisation is about. It is about the learning, and it's about taking things away and saying, you know, we're evaluating, we're working on it, we're doing a cycle of learning and bringing back. So I've enjoyed that, and like you said, it is my first board, so I'm just getting used to the hot seat and what's expected. So thank you very much.
That's great, thanks. Colleagues, can I just say that if you could all stay on this link once it's gone off the live, because I just want to talk about logistics for our part 2. Having said that, we will now close our public meeting. Thank you very much.